Hi everyone, thanks for listening to my presentations. Today I'll be talking about congenital tuberculosis and neonatal tuberculosis. Are you familiar with this topic? If you are not, no problem. If you are, that's fine. Okay, let's go. Congenital tuberculosis is a rare disease. I'm personally glad to know that because we don't want that, right? It is associated with tuberculosis affecting the endometrium of the uterus, otherwise known as TB endometritis. Or it could be through disseminated tuberculosis in the mother. That is, the mother who probably developed latent tuberculosis became reactivated and developed pulmonary tuberculosis, then disseminated or spread beyond the lungs, then to other organs in the system, and there's possibility of vertical transmission, that is through the placenta to the fetus, or could be by fetal aspiration of the amniotic fluid, even while in the womb. It's possible, okay? Literal aspiration of the amniotic fluid containing Mycobacterium tuberculosis. So the child has aspirated the causative agent into its own system. Or it might be aspiration during delivery, okay, intrapartum. So these are the various ways through which the fetus could acquire Mycobacterium tuberculosis in utero while still in the womb or during delivery. What are the clinical features? The affected infant, the neonate delivered with congenital tuberculosis will have respiratory distress, develop fever, and when you check the liver, it's likelihood of hepatomegaly. The spleen will not be spared, with possibility of splenomegaly in them. When you try to feed them, there will be poor feeding or poor sucking and become lethargic and of course irritable. How to make the diagnosis? Tuberculosis test could be done, and you could confirm that with interferon gamma release assay, or many people will go straight for interferon gamma release assay, IGRA. To be safe, you can have the mother screen for HIV, because if you screen the child for antibody at birth in a mother with HIV positive, the value is going to be high, right? But you can do viral culture, take the blood to get a viral load. But when you screen the mom and the mom is negative, you don't need to bother about HIV in the child. You can have lumbar puncture done for CSF. And what are you going to do with the CSF? Of course, alcohol acid fast bacilli test, nucleic acid application test, or Mycobacterium tuberculosis culture, which is the gold standard. You can have the placenta for histology, and of course take sample from the placenta for AAFB, nucleic acid application test, and of course for culture. How do we treat? I'll not waste your time going over the details of treatment right now, because I'll make a separate video on treatment of tuberculosis. Neonatal tuberculosis. This is due to postnatal exposure. More cases of neonatal tuberculosis than congenital tuberculosis. It's likely from the mother, or we don't place the entire blame on the mother, right? It might be from the father as well, or any caregiver, or even the grandparents that may be helping with nursing. But any of this, the mom, the dad, the caregiver, or grandparents will likely have pulmonary tuberculosis, and they are infectious at that stage. Caregivers must be evaluated in both cases, that is, in both congenital and neonatal tuberculosis. Diagnosis is like in tuberculosis in infants and children. You can check my channel for that. Treatment is like in tuberculosis generally, but the dosages of the medication will be in milligram per kilogram. So we're going to measure that. Prevention. In fact, this is the aspect of medicine that I love the most. If we can prevent, then we don't need to bother ourselves about side effects of medications. We have to treat latent tuberculosis infection with INH on a daily basis or twice weekly for 9 months, if we're able to identify that. If we do that, the mom and the newborn will be safe. We should add pyridoxine to INH to prevent the neuropathy associated with INH. Active tuberculosis in a pregnant woman should be treated with INH, rifampicin or rifampin, ethambutol and pyridoxine for 2 months. Then INH and rifampicin for the next 7 months. Don't discourage breastfeeding, but please don't give pregnant women fluoroquinolones, including breastfeeding women. Don't give them fluoroquinolones. Capromycin, amikacin, kanamycin, and streptomycin should be kept off the table for them. And with that, I've come to the end of this short presentation as per congenital and neonatal tuberculosis. Kindly subscribe to my channel. You can ask me any further question that you like, or you suggest any difficult topic you want me to handle. Thanks, I appreciate it.